Hi everyone, welcome to the very first webinar on disaster research. I will hand off to Kevin Yeski, who will be our moderator today.
All right, thank you. Welcome and thanks for joining the webinar today. This is the first webinar in a series that will explore the many aspects of disaster research, including the gaps, the challenges, and the rewards, with a focus on how we as a nation can come together to provide the best science in a timely fashion to address health emergencies and disasters in the US and globally. Our host today is the National Academies for Sciences, Engineering, and Medicine and the Action Collaborative on Disaster Research, which evolved from the former National Academy Standing Committee on Disaster Research and represents an ongoing effort by multiple stakeholders to foster improved processes and platforms for developing and implementing needed time-critical data collection and research in response to disasters. Part of the original vision of this undertaking was to provide a venue at the National Academies for convening idea generation and information sharing during the initial stages of a public health emergency. Along these lines, the National Academy Standing Committee hosted rapid workshops for Superstorm Sandy and the Ebola and Zika responses to help inform research priorities. The Action Collaborative continues these efforts and is associated with the National Academy's Forum on Medical and Public Health Preparedness for Disasters and Emergencies. We hope that you find this series answers many of your questions, encourages you to continue in your disaster research pursuits, and motivates you to engage in disaster research. Today's speakers are noted disaster researchers and have decades of experience in the pursuit of expanding the knowledge of disaster science. Can I have the first slide, please? I put this slide up just as a representation of some of the areas that this webinar series will touch on, and you may hear more details about this as we go forward in today's webinar. And Aubrey Miller and I put this slide together about 4 or 5 years ago as we were thinking about disaster research and disaster science and the need to have a coordinated, integrated, multidisciplinary approach to disaster research. The House of Disaster Research is built upon an engaged, coordinated, and empowered community that integrates laws, frameworks, jurisdictions, communities, and resources and professions. There's room at the House for everybody. The goal is to have a national, not a federal, but a national framework that includes research in clinical care, public health, earth sciences, physical sciences, social sciences, human services, emergency management, and basic science research. It's a partnership across public and private sectors. With the expansion of knowledge while the expansion of knowledge is a noble goal, we need to emphasize that the ultimate goal of research in disasters is to help communities solve local problems and build community resilience. Our speakers today will touch on these and many other ideas in the next hour. And at the end, we've reserved time to ask questions of the panel. So let's get started. I'm going to introduce our panelists at the beginning and then turn it over to Aubrey Miller, who is our first speaker. Dr. Miller is a board-certified occupational and emergency environmental medicine physician. He's currently the senior medical advisor to the director of the National Institute of Environmental Health Sciences, where he oversees legislative, policy, strategic planning, and coordination of environmental health issues and activities among U.S. federal agencies, Congress, academia, and other stakeholders. He currently leads the NIH Public Health Emergency and Disaster Research DR2 program, which focuses on improving national, international research capabilities through enhancing policies, infrastructure, training, and integration of stakeholders, especially academia and impacted communities. Our next panelist is Dr. David Abramson, who is a clinical associate professor at NYU's College of Global Public Health and the director of the Public Health Disaster Research Center at NYU. His work is focused on population health consequences, interactions of complex systems, and risk communication strategies associated with Hurricanes Katrina and Sandy, the Joplin tornado, the Deepwater Horizon oil spill, H1N1 pandemic, and Zika, among other natural, technological, and man-made disasters. Before joining NYU's faculty, Dr. Abramson was the deputy director at Columbia University's National Center for Disaster Preparedness at the Earth Institute. Prior to entering the field of public health, Dr. Abramson spent a decade as a national magazine journalist, having worked at or written for such publications as Rolling Stone, Esquire, and Outside magazines, and is a nationally certified paramedic. Dr. Tom Kirsch is the professor and director of the National Center for Disaster Medicine and Public Health at the Uniformed Services University. He is a globally recognized disaster scientist and educator who has conducted research following dozens of disasters nationally and globally, resulting in more than 150 publications. And our last speaker is Dr. Karen Lutrick, who is an assistant professor in the Department of Family and Community Medicine in the College of Medicine at the University of Arizona and the director of the National Foundation of Emergency Medicine. Dr. Lutrick's work focuses on emergency preparedness, Latinx health, and dissemination and implementation scientists. And with that, I'll turn it over to Dr. Miller.
Great, and Tom Kirsch is going to come immediately after me, and then it'll be David. So, hi, I'm Aubrey Miller. Good afternoon. And as noted in the title of today's discussion, Back to the Future. The concept of this series of webinars is not new, as we will discuss shortly. However, the need to move the nation's health, emergency, and disaster research capacity forward is more pressing than ever. Next slide, please. Here is a graphic produced by our friends at NOAA showing billion-dollar weather and climate disaster events from 1980 through October of 2020. Of note, the data for 2020 does not yet reflect Hurricane Sally or Delta or the historic Western wildfires. When looking from left to right over the past 2 decades, it is clear that the consumer CPI adjusted costs and frequency of these events are increasing at alarming rates. The total cost over the last 5 years exceeded $550 billion, averaging more than $110 billion per year, a new record. Next slide, please. Our efforts to address the COVID-19 crisis, back one. Oh yeah, okay, there you go, yeah, that's, go to the one before this, sorry. That's it, that's the one, all right, that's it. Our efforts to address the COVID-19 crisis, now totaling over 217,000 dead, as well as these other major events depicted by these Time magazine covers, underscores the sentiments expressed in a recent letter by Bill Fogarty, former CDC director, to Dr. Robert Redfield, current CDC director, and published recently in USA Today, where he emphasized that the best decisions are based upon the best science. Next slide, please. With that said, the need for timely science to better understand and effectively address the full range of issues and concerns subsequent to health emergencies and disasters is a paramount necessity that has been part of a growing chorus of calls to action over the past decade. In April 2011, the National Biodefense Safety Board called for the inclusion of scientific investigations as an integral component of the disaster planning and response, noting that public health emergencies demand a range of well-planned and coordinated efforts, including the effort to facilitate the conduct of essential research ultimately aimed at development of effective clinical and public health interventions. Such research is likely to be conducted at multiple sites and to engage multiple investigators and populations of potential human subjects. Next slide. In March 2013, senior leaders from HHS, CDC, and NIH once again sounded the call to action. In this New England Journal of Medicine article, noting that the knowledge that is generated through well-designed, effectively executed research in anticipation of, in the midst of, and after an emergency is critical to our future capacity to better achieve the overarching goals of preparedness and response, preventing injury, illness, and disability, and death, and supporting recovery. Next slide. In June 2014, NIH, CDC, HHS, and the Academies Institute of Medicine sponsored an important workshop that brought together a group of over 200 stakeholders from government agencies, academia, professional associations, emergency management, industry, and the private sector. The workshop sought to explore the challenges as well as advance opportunities for improving the nation's public health research capacity in response to disasters. Challenge areas identified included the lack of a formal way to activate and coordinate research amongst agencies, academia, and other stakeholders. Difficulty in providing time-critical funding for both government and non-governmental research efforts. Slow reviews of research protocols involving human subjects. Lack of ready-to-go research tools and protocols to allow for timely implementation. Lack of trained researchers to design protocols and quickly gather perishable data in the field. Lack of meaningful inclusion of community stakeholders as a true part of the research efforts. Next slide. In 2017, in this 2017 report, the National Academies Committee reviewed the clinical research conducted during the 2014 to 15 Ebola outbreak in order to better understand the constraints that affected the design and implementation of human clinical trials. They noted that strengthening capacity in clinical care, public health, and health research systems is now an urgent and necessary requirement if this sort of epidemic is to be prevented and controlled in the future. How prescient given today's coronavirus crisis. Next slide. More recently are these two additional reports, one from AAAS, Science During Crisis, released in March 2019, and the other from the National Academies, Evidence-Based Practice for Public Health Emergency Preparedness and Response, released this past July. This latest review of the field of public health disaster science will be discussed by David Abramson later in this webinar. These reports again reiterate the call to action to transform the nation's infrastructure, funding, and approaches to be able to acquire and apply the best science for these situations. Next slide. These issues are not only confined to the US, but are part of a growing global concern as well. As noted here in the Sendai Framework for Disaster Risk Reduction 2015-20 to 2030, of the 4 priorities for action, the first priority calls for understanding of disaster risk, recognizing that risk management should be based upon an understanding of disaster risks in all of its dimensions, including vulnerability, capacity, exposure of persons and assets, hazard characteristics, and the environment. Next slide. So what are we talking about when we say research? What we are focusing on here is our collective need to be able to move beyond situational awareness and public health practice towards being able to effectively design, implement, and gain results from a diverse array of multidisciplinary data collection efforts, investigations, and studies that help to answer such fundamental questions concerning how to best reduce health and environmental impacts, as well as promote the well-being of individuals and communities, both in the short and long term. We need to be able to answer questions such as, is it safe? Did our efforts help? What are the physical and mental health impacts, both acutely and longitudinally? What is the safety and efficacy of medical diagnostics and treatments? What are the risks of exposures and contamination? What are the most important risk factors for recovery and longer-term resiliency? Importantly, how do these situations affect our most vulnerable populations, pregnant women and children, the elderly and those with pre-existing conditions, or environmental justice communities with a higher history of adverse exposures? To put this in real terms, I was recently contacted by a resident of California who was impacted by the wildfires. She reported that areas all around her home were burned, but fortunately her home and property survived, but was now covered with ash and dust from the fires. She wanted to know answers to basic questions that affected her family and her community. Is it okay to live in my house with my children and pets? Can they play outside? Can my livestock graze? Can I eat from our garden? What are the long-term risks of living here? These questions arise time and time again, yet we do not effectively gather the critical data to spawn generalizable knowledge to provide the needed answers. Next slide. As noted by the increasing calls to action, our current system has not and is not serving us well. However, there are models for success for designing and implementing transdisciplinary collaborative research at the local level. A nice example of this will be presented by Dr. Karen Lutrick later in this webinar. Karen will discuss lessons learned from the NIEHS training workshop held in Tucson in 2019, one of 4 such workshops to date, where multiple stakeholders were brought together to explore how research needs can be addressed at the local level through improved preparation, engagement, and networking. Next slide, please. Beginning today and in the coming months, we will discuss how we can better leverage our vast investments, expertise, and skills across the nation to improve response, recovery, and enhance preparedness. We need you, our diverse community of public health professionals, healthcare providers, academicians and researchers, students, private sector partners, and others to engage in this discussion as we explore issues and opportunities for progress through community engagement and crowdsourcing, such as USGS's Great Shakeout, enhanced IRB reviews, the National Science Foundation's Converged Infrastructure, new ideas from NIST for data integration, and sponsored multi-stakeholder training models that facilitate applied research. Next slide. Next, Dr. Tom Kirsch will provide a deeper dive to help us better understand to better understand the under the hood problems with the engine that should be powering disaster health research and the state of our nation's disaster research enterprise. Again, thank you for joining us in this effort to move the nation's health emergency and disaster research capacity forward. Thank you. Next to Tom.
Thank you, Aubrey. While they're getting the slides up, I might as well get started since we're trying to be quick for time for questions. I'm the director of the National Center for Disaster Medicine and Public Health. It's a federally based center that was stood up by a presidential directive 10 years ago and is an interagency center that reports to the Department of Defense, Department of Homeland Security, Department of Health and Human Services, the VA, and the Department of Transportation. Our focus is on disaster science and education related to health and public health. I have to say up front that I'm a federal employee and therefore these discussions are mine only and don't reflect the USU nor the Department of Defense, and the research is mine only also. So what I want to do is to follow on this background that Aubrey provided, the history and why this is such an important topic. We decided we start looking into what the specific constraints and problems were with disaster research that required all of these discussions. So we did a series of studies, 3 specific studies, 2 on funding and 1 looking at the experts' opinions of the area and disciplines. So I'm going to present 2 of the quick studies, the funding studies first. They're referenced here. You can see them for details. I have to be brief, so I'm not going to go into a lot of details. One important caveat looking at this, we looked at funding related to disaster health and public health. We intentionally took out money that goes to biopreparedness and bioterrorism because that's an entirely separate enterprise funded by BARDA, partly the NIH, and is a almost $14 billion annual funding mechanism. So that's not included in these numbers. And we also eliminated any money that was not related to health and public health because, again, there's billions of dollars that go to the different aspects of preparedness and response, particularly on the hazard side, where organizations such as NASA, NOAA, the USGS, and others in the DoD fund very large projects, satellites, modeling, and other initiatives related to describing hazards, predicting their impacts, et cetera. So our focus was purely health and public health related research. Briefly, our methods is we did a keyword search on usspending.gov, which is the source of all non-secret federal funds and grants. You can go look at what everyone spends on everything there if you're interested. And again, you can see the methods on our papers.
Hey, Tom, this is Kevin Yeske. Are you advancing your slides?
Oh, I'm sorry. Yeah, I haven't been telling you this. Skip 3 slides forward, please. These are the 2 papers I referred to. One more slide. This is the results. So the first study, we looked at funding for a 6-year period, 2011 to 2016, just to get a general idea of where, again, disaster health and public health research money goes to. There was a total of about $70 million identified that year. Of that, about 50%, slightly over 50%, went to engineering. And you can see the distribution for the rest. Social science got the next piece, and medicine, medical sciences got the smallest slice of the pie. Why is that? Probably because the National Science Foundation has specific funded programs for engineers and some social sciences that are dedicated disaster research. And there are no other programs in any other organization except the CDC has a very small annual budget of somewhat less than $10 million a year that goes to research related to public health preparedness issues. And so again, the rest of that funding mostly came out of the CDC budget. Next slide, please. This is the variance over the years during those time periods. As you can see, it ranged from, it quadrupled over the course of different years. It's entirely inconsistent. And the funding is very low. In 2016, for example, it's only about $8 million. I sadly joke that the NIH spends more on a single study for toe fungus in rats than the entire budget of disaster health. And here's the graphic example. Next slide, please. So we did this little diagram to demonstrate funding. The pale blue circle is the NIH annual budget. It's the budget from 2016, actually, which was $31.3 billion. The National Cancer Institute alone, the darker blue circle, is $5.3 billion. The CDC or Public Health Emergency Preparedness Program, which helps to prepare states and counties for disasters, was $838 million. The entire medical disaster, or the entire disaster research funding for that year that we could find related to health and public health was $8 million. If you compare that to the $550 billion that Dr. Miller mentioned as being the annual impact of disasters on our country, that's 0.002% of the entire impact on the country. So as you can see, our spending is exceptionally low in the area of disaster health and public health. Our next study, we compared, and this is a little misleading because these data were actually from 2008 to 2016. We compared mapping back to what the CDC describes as the National Public Health Emergency and Preparedness Response Capabilities, which are the goals the CDC has described as being critical for our nation to respond. We mapped the money back over the course of that time to those specific areas. As you can see, of the 34 potential target areas, only 12 of them received any research funding during that time. You can see the distribution of research funding across these different disciplines varies hugely with information management, because you get to do cool things like buy computers and do software programming, getting the most funding. And again, I'm not able to show the chart, but the funding over these different areas over the course of the decade was extremely low and varied greatly year to year. So next slide, please. We conducted a qualitative study then. We wanted to find out what the experts felt about this and how it impacted their careers. So we did a qualitative modified Delphi technique using 3 groups of experts from the discipline of social science, medicine, and public health. And we asked them their thoughts and then did rank testing, et cetera, to come up with key issues. This is an example of how they felt about the evidence in terms of quality, quantity, and continuity. How good was the evidence that we did in these specialties? As you can see, the social sciences are highest in each category, but it's barely over half. So in general, the overall rating of evidence is about, mediocre, it's okay. We honed down onto specific issues, and here's some quotes from the experts that I just want you to kind of mull over as I talk about some of the other issues. We went on to develop our overarching themes, and these were, go to the next slide, please, that the funding is limited, inconsistent, and episodic, which is the key issue related to disaster health and public health research. The funding is typically ad hoc. It's disaster event specific. It comes and goes when there's big events. It disappears a few years later. And the funding tends to be very politically influenced by state and federal governments. The next big theme that was identified, the critical gap, is within the sciences, there's an absence of theoretical and conceptual frameworks that define and shape the field. This again leads to a lot of ad hoc research, duplicative research, and non-building research, and that's an issue. All of this leads to the following, and I can attest to this personally, as I'm sure everyone on this panel can, who's been an academician for most of their career. It's a really hard career. Lots of money one year, all gone the next. It's very hard to recruit faculty. It's very hard to maintain faculty. It leads to papers being repeated over and over again as new people move into the field and then move back out. The pool of researchers is small. It's aging. There's a lot of people retiring. And there's not a lot of interdisciplinary research that's required. So that's kind of a summary of the thoughts. And to summarize again for you, funding for disaster health research is infinitesimally small. It is thousands and thousands of times less than that of any other specialty. It is infinitesimally small compared to the overall impact of disasters on not only our society economically, but on the health and public health of our people. And something needs to be done about strengthening this. And I believe that Dr. Abramson is going to move on to talk about that. I want to mention one big step. The National Center has been working on legislation with the offices of Senator Schatz and Senator Cassidy to stand up what we call a National Disaster Safety Board, based on the National Transportation Safety Board, which would be an objective measure of the impact and make specific recommendations to improve disaster response going forward. That legislation was put forth last week, and I think that's an important thing for all of us to look at and to consider promoting. Thank you very much.
So thank you, Tom. Let me share my screen so I can open up. So first of all, thank you to Aubrey and Kevin and Tom for offering all these comments. And I think this is going to be the next in line to demonstrate what happens when you don't fund a discipline. What I'm going to be presenting today is the results of a 3-year study that was conducted by the National Academies of Sciences, Engineering, and Medicine, the National Academy of Medicine in particular, and funded by the CDC. The committee itself was composed of methodologists with expertise in evidence grading, by disaster researchers and by practitioners. The comments that I'm offering today, though, are mine alone, although I'm going to be trying to do my best to represent the sentiments of the whole study team. So the CDC gave us a large and complex charge, and I'm really only going to focus on one aspect of it. Part of it was that they did ask us to develop a methodology for evidence grading. You heard from Tom, his study using the Delphi method. And so we spent some time looking at FEP capabilities, the public health emergency preparedness capabilities, taking some use cases as case studies, and developing an evidence grading methodology to provide an evidence to decision framework. But one of the charges that the CDC gave to us was to provide recommendations for future research to address gaps and processes, and really to evaluate the disaster science field. As we were thinking about doing that, one of the first things we did is we considered what is an optimal public health emergency and preparedness system. Because in order to understand how well we've developed a research base over the years, we have to think about, well, research for what, to do what, and to encompass what. And so we came up with this as our working framework for what an optimal system might be. And when you look at it, if you think about outcomes from a system, there are outcomes to the right and to the left. And to the right, they are related to response and recovery, and to the left, they're related to preparedness and mitigation. And a fully functioning, highly optimized system should be able to produce these kinds of things. From a response and recovery aspect, you can imagine that a fully functioning system would be equitable, would be efficient, would minimize social disruption, limit disease spread, minimize mortality and morbidity, and provide equity to all of its stakeholders. On the other side, this optimized system would also be fostering and preparing a resilient community, and fostering a prepared and resilient system, and allowing this system itself to be interoperable and sustainable. Clearly, that the middle of this framework is where all the work is getting done. And it's, as we all know, is not just being done by governmental public health, it's being done by a number of sectors. It's being done by federal, state, and local agencies, by health systems, by emergency management, and then by a variety of community-based institutions and emergent institutions throughout. And for us as researchers, it's critical to understand what this system might look like as a meta system, so that we can begin to ask the questions, does what occurs within this box, within this system, lead to the different outcomes? Can we make a case that we're doing the things that are actually producing good outcomes? And so one thing that the study did pretty early on was it commissioned a study of the broad base of evidence of public health emergency preparedness and response. And one of the ways of looking at this, and I'm not going to go over all of the details other than to say this was conducted by a team at the Harvard School of Public Health who did a scoping review for us. They identified 1,100 studies that were evidentiary studies, meaning that they were looking at evidence of effectiveness and impact. And of those 1,100, they were able to identify only 72 quantitative studies that were looking at impact in the United States. Within those 72 studies, we had them divided amongst the different capabilities and look at whether they were focusing on individual health outcomes, non-health outcomes, process outcomes, system level, or cost. And what you would see here is really how many empty cells there are, which is where all the absence of evidence exists. And even in those cells where there are appear to be a clustering of studies, there really aren't that many. We're talking about essentially a handful. One thing that may be hard to see is that those bubbles or triangles that have hatches in them are models. They're not drawn directly from disaster data, they're drawn from training and from modeling studies. And so the point is there's not a lot of data that's coming directly out of actual disasters that is informing the field or providing evidence for most of the work in the capabilities that is being conducted presently. So that leads us to a lot of the challenges of why is there not better research? Why is this research base so thin? There are any number of reasons. You've heard from several of the panelists before me, and I'm sure all of you within this great ecosystem of disaster science have experienced a lot of these yourself. So the first one, if we begin in this cycle, is the challenge with identifying and prioritizing research needs. There's really no existing or extant mechanism for us to, as a field, think about what the research needs are and prioritizing them. Secondly, there are a number of challenges, challenges of funding, of getting access to populations, and of conducting rapid IRB protocol reviews. There are infrastructure and implementation challenges. In some ways, we don't have a workforce that's sustainable and ready and available on a consistent basis. There are the logistics of actually getting into the field. There are all sorts of data collection issues of identifying pre-event data, coordinating data, sharing data, and integrating it, even bringing in big data to a lot of these problems. And then lastly, there are challenges that we experience coordinating and managing relationships and engagement. So there are a variety of networks, but they're often small. They're not coordinated amongst the entire disaster ecosystem. They're getting better. The DR2 that Aubrey referred to before is obviously one exceptionally useful mechanism to begin to bring us together to share best practices. And so our conclusion as a study was that the science underlying the nation's response to public health emergencies is seriously deficient, hampering the nation's ability to respond to emergencies most effectively to save lives and preserve well-being. And what we needed was building blocks for fostering the discipline of disaster science, sustained and comprehensive interest, a way to develop this coordinated research agenda, and then obviously the foundation of resources, assets, and networks that we've begun referring to. And it's not as though our colleagues in other sciences have not figured out some of how to do this. In the social sciences, with funding from the National Sciences Foundation, there are a series of these extreme event reconnaissance teams or networks that have been created. There are 7 of them. 5 under the banner of the Natural Hazards Center at the University of Colorado. And this is an ecosystem that allows the disaster scientists within each of these fields to develop disciplinary strength and help advocate for funding. And it allows the NSF also to easily move money into the field and identify research priorities quickly. And I think the question for us is, why is there not a public health extreme events research network, a FEAR? And so among the recommendations that our study came out with, and perhaps the most critical for today's discussion, is that we recommended that CDC in particular work with other funding agencies to develop a national public health emergency preparedness and response science framework, or a disaster science framework, that could ensure the resources, coordination, monitoring, and execution of both public and private sector research. And essentially, this would involve improving the coordination and alignment amongst all of our collective efforts, supporting the notion of disaster science as a unique academic discipline, creating a common research agenda, supporting meaningful partnerships between the research and the practitioner community, and helping to prioritize the strategies and mechanisms for translation, dissemination, and implementation. Beyond that, the other recommendations that are key to today's discussion was to ensure infrastructure and funding, improve the conduct and reporting of research. And in this case, we looked at after action reports as a potential source for the disaster science community, recognizing many of the limitations of those types of reports, and made a variety of recommendations about ways of bolstering that and strengthening it so that they offer higher quality data for the disaster science community to use, and supporting a pipeline for workforce development and ongoing training, and then most critically, ensuring the translation, dissemination, and implementation of the research. And as you've heard from my co-panelists, this is not the first. This is only the next in a long series of studies, committees, workshops, that have essentially arrived at more or less the same findings. And so what you see here is just a snippet of some of the findings. Aubrey introduced some of these before in terms of the Lurie and other article in the New England Journal of Medicine in 2013, the National Biodefense Science Board recommendations, the AAAS recommendations. And what you can see is that many of our collective works have been pointing to the same thing. Our recent study from the Academy was looking at developing the large framework and the large system for doing this, but then each one of these other studies and articles has pointed to very specific operationalization of how to do these things. So for example, if in our study we were looking at how to improve coordination among the research community, Lurie and others said, perhaps it's useful to identify and roster experts to plan for a ready reserve of citizen science and clinicians. AAAS noted that it was important to address divergent scientific opinions, data, and results during a crisis. So that's actually the coordination of researchers during the actual event itself. All of these things together really serve as a beginning point for us, a template for the kind of conversation that we need to have to develop this science agenda and to move the disaster science community forward. With that, I'll stop. I do want to acknowledge from the study perspective, our two incredible study directors, co-directors from the National Academy of Medicine, Lisa Brown and Ornan Downey, as well as all of my co-panelists on that study. And I'll turn it back to Kevin.
Karen, let's go to you.
Okay, yeah, that sounds great. First of all, just thank you to the National Academies and the panelists for inviting me to present today. I will be sharing, as Aubrey alluded to, our experience from the DR2 workshop that we had in Tucson, and how that has kind of helped us with our response to COVID and our research. So the disaster research response workshop that we held in Tucson was in February of 2019. We used a train derailment scenario, thinking about the release of chemicals from rail cars in a highly diverse population dense and vulnerable community here in Tucson. After we started planning, there was actually a train derailment really close to where we were planning on having this scenario. And our focus was really sort of these issues of short and long-term health impacts, medical care, and environmental contamination. So really key goals for our workshop were really thinking about the population data and research of the impacted community, also looking at the clinical data and research, thinking about sort of the overall effect of the train derailment, treatment safety and efficacy, and thinking about how to integrate them. So that a lot of the panelists have talked about the need to really integrate data. And that was definitely a focus of our workshop. We were as inclusive as possible, and that involved also our IRB. So we did a mock IRB session, actually approving a protocol that we would potentially use in this type of scenario, which came in really, really handy once we started doing COVID-19 research, as well as many stakeholders as we could. We had over 120 participants. We had the sort of traditional federal agencies, academic partners, as well as some state and county, but also some NGOs, and community groups, and we also did some outreach and integration of tribal communities in our workshop. So kind of jumping into the lessons learned. So one of the things that was really valuable for us was this idea of a multidisciplinary approach, and we tried to start in the planning and then implement that all the way throughout to the workshop and then beyond. We included sort of the traditional academic scopes, our academic disciplines, so environmental health, population health, our clinical colleagues, pharmacists, but also the poison control, again, our human subjects. Because of the population of interest, we also included groups like our translation and interpretation, some community groups that worked with the vulnerable populations in that affected community. A lot of community members and students was a really important group for us to include. The focus was really kind of all throughout this idea of integration. So thinking about what are our shared priorities. We have these shared participants. So really thinking about the disaster or the train derailment as like sort of person-centered. So we typically in our sort of academic, we think about like, well, they come into the clinic and then we go to their house and then they go to the grocery store and we survey them, but really that's the same individual. And so how can we make sure that our response and our data collection is really centered on that individual? How can we share data as much as we can to minimize the impact? This shared responsibility of sort of working with and for the community to make sure that we understand, we're collecting as much data as we can, but responsibly. And again, this idea of sort of this data sharing, so these traditional streams of clinical, population, environmental, sharing them kind of up and down and then longitudinally across to see if we could map out how they all kind of go to a single registry. You know, other value and sort of important aspects that have really benefited us was that we really situated in like local real world contexts. So we didn't, we made sure that our solutions were practical and sort of rooted in our actualities of the politics and you know, capacity and resources and things. And it really helped us establish meaningful guiding principles that have been really critical for future research, but especially now during our COVID response. We developed in that sort of process some practical and scalable infrastructure. So our data sharing model we have a much more complicated version than was on the last slide, but it's ended up being incredibly useful because we use that as sort of a common ground with our IRB and our HIPAA. We kind of decided what mattered, when they needed to be involved, and sort of the framework that we could work within each of those pieces, and that's really paid off. Again, it streamlined and shortened our time to COVID-19 response. We were up and running within weeks instead of months. We were able to build off of existing collaborations and relationships because we had these common goals and operating procedures. And again, we had some regulatory protocols that were already approved, so we could literally just call them and say, we're going to start doing what we talked about last year. And they trusted us because we'd already worked through a lot of those details. again, so just to reiterate our guiding principles, because we really feel like they're incredibly simple but really important. Our goal is to coordinate in order to minimize participant burden. So really thinking about our community that we serve here in Tucson and the state of Arizona. So this is common or harmonized baseline questionnaires. So we're not asking the same person 5 different versions of when were you sick or what kind of household do you live in. We're really like able to share and harmonize that. In setting up projects that allow for the ethical and legal sharing of data and participants. So we've really kind of worked to make sure that we're all asking if participants are being willing to contact it for future research. If they say yes, we're sharing these standardized baseline questionnaires, and we're linking projects in a way that reduces competition, reduces the impact. Not everybody is calling a single participant trying to sort of get them into one of 15 different studies, but we're really working collaboratively from population all the way through clinical trial. And the last thing, which is really important to us, based on our community and just kind of our general values, is everyone is welcome. So we are a fully inclusive space. Everybody has a seat at the table, including students, community members, and individuals that don't have any experience doing this kind of work, but just want to be involved and make a difference. And that has really been beneficial. So the practical sort of the meat, right, what we're actually doing, we've really kind of stuck to this idea of, clinical and population and how we link them. So on the clinical side, in addition to some, standard clinical trials like most probably academic medical centers are doing, we're really working on building this kind of integrated inpatient and outpatient clinical data registry that helps us understand the impact of COVID, the severity, and track some treatments so we can do some outcomes and dissemination research, right? Understanding how clinical practice has changed. It's a collaboration on inpatient and outpatient. So it's family medicine, emergency medicine, and critical care. Again, trying to understand the full severity of the disease. And again, thinking about person-centered. So working from the person, the individual, and kind of where they're accessing our healthcare. We have an accompanying biorepository to support our bench researchers, and then they can also use the clinical data. So again, really trying to think translational throughout the spectrum. And we have about 730 individuals so far in our registry, split between inpatient and outpatient, and there's about 15 that live in both. On the population side, we're working on a population-based cohort to understand the short-term and long-term effect of COVID-19. This is also an opportunity to look at some social determinants of health and some social aspects, right, that we don't always capture in our EMR and our clinical registries. It's extremely collaborative. It's 6 colleges, 2 universities, and health departments. And again, we're working on this collaborative recruitment and data collection, and we have, as of this morning, over 1,500 individuals enrolled, and that's called cohort. And so we're really thinking about linking these. Originally, in our sort of original model, it was like a train derailment happens and we kind of collect data and we pool it. But what we've realized in the pandemic is that it's really a series of like Venn diagrams. So our population is existing in a variety of circles and a variety of spheres. And so how can we better understand the impact of COVID on our community from the sort of the full person-centered aspects? So thinking about kind of nesting all of these data sets, the population, the clinical, and the biological, again, through collaborative recruitment, aligned instruments, and then we're working on some ancillary studies to link all of these data streams. So to ask our individuals in our population cohort, where were you treated? And then we can kind of look at their social, the stuff that they're telling us about their lives and how they were impacted, but also their clinical course of treatment. And then with that additional biological. So again, it takes a lot of people to do this work, and in the spirit of collaboration, I just wanted to sort of acknowledge the larger team, mentors, specifically NASEM, the DR2 and NIHS for their ongoing support, and just our wide variety of collaborators that have been working to kind of help us put all these pieces together and then really apply them to respond quickly and efficiently and in a way that really we think benefits our community instead of really like burdening them. And with that, I will say thank you.
Well, thanks to all our panelists today. We have time for questions, and I'm going to start off by asking a question about an analysis of the barriers that advance the idea of disaster research as a priority? And is it a matter of being too focused on the medical side? Is it a matter of not advocating proactively enough? Is there not a demand for this? I'd like to open that up just for quick responses by the panelists. What do you think that that haven't been discussed yet, but what are the barriers to moving this forward?
Yeah, this is Aubrey. I guess I'll start, and it's because the space is not owned. Also, there is no coordination of federal agencies with respect to it or our efforts. We have conversations which are ad hoc with other agencies, with our academic institutions in response to these situations, but there is no federal coordination or organizational or other platform. And I'm not saying it has to be federal by any means, but there is no organizational centering effort to it. We do that with our response efforts, the response to a federally declared disaster. FEMA comes in and they coordinate. We don't have that type of system, whether it's even within the Department of Health and Human Services across agencies under that one department, let alone between departments. I think that is the beginning of a fundamental disarray that continues to project itself throughout the system. And I'll stop there and let my other colleagues.
Yeah, if I can just add, ultimately all financing that comes to the federal government is political. And so there's not a political move to finance this stuff. There has not been widespread recognition. And I think that needs to be ramped up across the board. And discussions like this help to bring forth the importance of this topic. And again, when you look at the minuscule, like 0.0002% of the impact it goes into research, you realize how important that is. And that's why I think this legislation being put forward to actually develop the first ever kind of objective measure is at least a good start for this. There is some recognition now in Congress and the Senate that this is an issue that we need to address.
I think one of the issues is also the variability of the field itself. Disasters come in so many sizes, shapes, and forms across such a broad range. It's hard for any single entity to sort of look across all of this and imagine what a collective disaster science enterprise might be. So there's no natural home for that, and certainly not in a federal agency. It's sort of shared and divided amongst many. And then within academia, it splits into so many different disciplinary areas that that in and of itself, I think the variability and the complexity serves as a primary barrier.
So let me ask a follow-up that's related to this question then. If on the federal side, what do you think the federal home should be? And Tom, particularly directed at you, is since USIS and the National Center is the National Center, is that a potential home for this kind of coordination and integration?
I have to state my biases up front, being a scientist, but the answer is, of course, yes. I don't know. There's been talk about different agencies. There has to be a funding agency. NIST now is doing some work on post-disaster objective measurements with Hurricane Katrina and has done some funding. NIH, yes, but NIH doesn't cover lots of areas related to disasters and some injury stuff and other things, emergency medicine. So again, that doesn't necessarily fit their mandate. ASPR in the past has lobbied, I think, for disaster research funding, and the CDC. So to me, logically, probably HHS should be where this would be coordinated through, whether that's CDC or ASPR, but there has to be a line item that delegates, here's funds to do disaster research, period.
We might think about some distributed models too, as well. I mean, what we're trying to do is connect dots between different organizations that have differing capabilities, but one is to create a framework where they can work together, they operate together. We can help to prescribe elements of that framework that allow functionality at the federal level, but also bring in our vast investments across the country. We have the best in the world of experts in medical, environment, exposure science, toxicology. We're not utilizing nor harnessing this capability well at all, I mean, really poorly for these situations, and we should do much better. So if they think about what do we want to do, how do we pull in these resources, as Karen so nicely showed, what is being done at a local level of combining with federal support. You know, there's different ways that we can achieve this with our partners in a more effective design. And, you know, public health has their capacity and their what they do. Our academic partners have great strength at what they do, but the two don't connect well. We don't create the platforms for those two to work functionally together. How do we let our federal agencies and others feed into that platform and engagement and strengthen that? We had a great discussion prior to this with the National Science Foundation of some of the, as David mentioned, and showcase some of the models and things that they've tried to develop in their geosciences and social science areas. And I think that's a nice, maybe a nice starting point to think about similar systems, you know, in health and other that allow us to try to facilitate this.
Just to add another concept, there may be some innovative platforms that we're not even thinking about. And in particular, I'm thinking about PCORI, the Patient-Centered Outcomes Research Initiative, which is sort of quasi-public. And it has built into it a funding stream in that it has hard money coming from health utilization. And it can fund research sort of independently. It's not quite as tied to appropriations and authorization in order to carry out its work. It has the capacity to provide that broad network option, the way Aubrey was just describing, as making it maybe you know, some type of a distributed model. It would allow a lot of different entities to come together. So I'm not suggesting that PCORI is the exact model, but that there may be other innovative models that we could think about, and would require that we sort of develop a set of criteria of what do we want this home to do? What kind of activities does it have to be able to do? Does it have, you know, translation implementation aspects to it, in addition to funding, in addition to agenda setting, in addition to networking? So there are many different functional areas, and the best one would be one that could be able to bring in all of those pieces of government and private sector and academia, et cetera, that can contribute to that and help coordinate it.
I think we have time for one last question, and that is, how do you see the disaster research response feeding and being connected to federal efforts at disaster risk reduction?
I'm sorry, I was trying to follow. What was that again, Kevin?
Disaster research response feeding and being connected to federal efforts at disaster risk reduction.
Okay, so for both federal and international efforts at disaster risk reduction are going on. So, you know, the science which underpins disaster risk reduction is what we're talking about here in so many ways, right? So how do we allow our science, our collective science, and strategically positioning science to contribute to disaster risk reduction? Fundamentally, disaster risk reduction wants to translate that science into effective public health and other dimensions of problem solving. And so that's where the two should join effectively together. You know, the CDC wants to do public health practice. They want to understand what's going on. They want to also translate information to the public quickly, but they need support from the research and scientific services to do that from the health side. We need that also for environment. We need that also in clinical and healthcare dimensions. So there's a number of different disciplines and areas here at the table, but a strategic science underbase to fund disaster risk reduction in its broad sense in public health emergencies and disasters to be able to effectively do that. And I think that's kind of that broad question that we're really trying to create this underpinning to do that.
Now, I would say at an even simpler level is this notion that there's so many of us who do disaster research and look at long-term and short-term recovery, but we don't have a lot of opportunities to have direct conversation with people who do disaster risk reduction as a practice. And so it's part of that translation gap where we need to have more of the research community have the direct conversation with those in the practice community that are particularly focused on disaster risk reduction to begin to understand how do we close that loop and begin to identify the ways that what we've discovered in research actually might have some benefit in preparedness, mitigation, and other risk reduction strategies.
Well, I think we're out of time. We'll stop here. Let me thank our participants and our question askers on the webinar, and also thank our panelists for great presentations and some thought-provoking concepts that were presented today. Again, this is the first in a series of webinars that we're going to be having on this topic, so stay tuned for the time and date of the next one. And with that, I will turn it back over to Aurelia for any administrative comments.
Thank you everyone for joining us, and we will make the slides and the recording available on the website in the next few days, early next week. And we look forward to the next webinars as well.
Thank you, everyone.
I will end the webinar now. Thank you very much, everyone.